per lecture for the new material. So that's from osseous grafts or bone replacement grafts through the last lecture of the semester. Then the first semester material, there's probably more likely about 2 to 3 points each from the first semester. So most of the weight is on the second semester, but you will have content from the first semester. Okay, then the format will be similar to what you had in the midterm exam. And therefore, the first series of questions will be case-based multiple choice questions. There'll be about 10. And similar to what we had in the first exam. So that means that you'll be given potential answer choices and there's one correct response. You will have definitions. I would expect about maybe 60 multiple choice, and there will be a treatment plan style question with a potential breakdown in discussion of treatment selection, rationale, meaning indications and contraindications for particular procedures. So you'll be giving like a diagnosis, a treatment plan, and there may be another case or scenarios for discussing different treatment selections. Okay. Are there any questions before I move on from talking about what the exam will be? Okay, so what I'd like to do now is just go over the case-based. There were some case-based questions in the midterm exam. And that would be, oh, there is a question. Okay, someone asked if what's the format for the treatment plan and the phases. So I can go over that. I think I have an example, and I'll go over that in probably a few slides. So I can go over the format. So as far as I'm going to start out with some of the case-based questions so that you have a thought process when you study. So this is the case, and I'm hoping that my window is not blocking yours. Can you see the entire image, the clinical image, the radiograph on the screen? Or is my chat window blocking the image? Okay, so maybe it's just blocking my view. Okay, so this is illustrating obviously a deep probing depth. And I'm going to just illustrate with the laser pointer the perulus above the tooth number 11. And then here you can see the radiograph, but this radiograph was from 2 years prior to this clinical presentation. And the scenario was the patient was a 45-year-old Caucasian female who had a history of subgingival scaling and root planing 2 years prior, but hasn't been back in a year and a half. So with this presentation, then really you were asked what the next steps were to determine a diagnosis. And if this is a 2-year-old radiograph, we can see there's some mild bone loss, but it probably doesn't match this probing and this swelling here. And I would hope that you'd want a new periapical. And anytime you see a swelling, We always palpate. We want to know the consistency. We want to know if there's pain. I'm hoping you wouldn't jump to doing a test cavity. And we would never want to puncture the perulus, because if in fact there is a draining point, we usually would want to use a gutta percha to trace that and then take a periapical film. And then usually we want to include a history of sign and symptoms. So this question was really trying to get you to distinguish an endodontic versus a periodontal abscess. So using a radiograph, palpation become important, as well as the history of the symptoms. Okay. Then the next part of that was, well, what do you need to make the diagnosis? And I'm hopeful that what you actually need would, it was supposed to highlight it, but hopefully you need probing depth, because if you want to know if it's periodontal or endodontic, you want to probe around the tooth to determine if you see a particular probing pattern where you have a precipitous drop or a gradual or generalized probing pattern. So a probing pattern that's generalized is more common for a periodontal abscess or a gingival abscess versus one that has a distinct drop down in just a very narrow site. Mobility wouldn't really help you distinguish endodontic versus periodontal. Bleeding probably wouldn't either, nor would recession, but certainly vitality testing would. That's why 1 and 5 rather, would be the best choice. So 1 and 5, tooth vitality and probing depth would be important. And moving on, if that probe registers 7 millimeters and the tooth is vital, what would the best diagnosis be? And hopefully the correct response being a periodontal abscess, because the tooth is vital. If we have a 7 millimeter probing depth and we didn't, if I go back to the image, we don't necessarily see a gingival enlargement here where the probing would not be related to the attachment level. It looks like the margin is close to where that CEJ might be. So it's probably, in fact, 7 millimeters of attachment loss with that probing, indicative of an underlying bone loss. Okay. Then another case that was part of your midterm was this one. And here, the patient was a 50-year-old, arrived at the office complaining of discomfort. And I have to move the chat window. And the maxillary molar, they had a bad taste. They said their gums always bled. Pockets were 4 to 6 millimeters or greater throughout this sextant. And the patient has a history of high blood pressure. Okay, so with that, looking at the images provided, what do you think are possible contributing factors for the condition? And you were given crown contour. Well, crown contour, if you follow my laser pointer, looks pretty darn plaque retentive. Violation of biologic width, well, that looks like it could have been a possibility, because here's the crown margin and the tissue sort of has crept away from that. And you can see over here on the mesial of the premolar, the tissue is covering the crown margin here. nifedipine-induced changes, well, we have no knowledge that the patient is taking nifedipine, and I'm really not seeing a suggestion of nifedipine enlargement. I see recession. And then the other choice, inadequate keratinized mucosa, well, there's quite a bit. If you follow my laser pointer, there's quite a bit of keratinized mucosa here in the maxilla if the maxillary molar is bothering the patient. But it does appear that this margin is in close proximity to the crest of bone on this side of the crown. So the best choice would be crown contour and violation of biologic width. Not sure why I can't advance the slide. Okay. Then the second part was what type of surgery would be acceptable or suitable to reduce the pocket or the pockets. And I think the key here is, in terms of amongst these choices, you could choose a gingivectomy, gingival curettage, open flap debridement, a coronally positioned flap. So as we look at this periapical film, I hope you can appreciate that there's advanced bone loss here, and there appears to be the need to reshape the bone and access a bony defect. So a gingivectomy would not be your first choice, because a gingivectomy can reduce pockets, but it won't give you access to the bone. And we wouldn't select it if there are bony defects. It also, there's a suggestion of periapical radiolucency here. Then gingival curettage is not considered a definitive pocket reduction procedure, especially when you have thick fibrotic tissue. And then a coronally positioned flap would actually maybe increase the pocket depth because you're coronally advancing the flap rather than apically positioning it. So the open flap debridement or an apically positioned flap would be the best choice. Okay. And then I think you had a couple of questions about matching the incision line to the appropriate procedure. So I'm not going to belabor this, but I just wanted to make certain that when you look at this diagram, A represents an internal beveled incision, and that can be used for a variety of procedures to raise a flap. So if you're going to raise a flap, you're going to use an internal beveled incision. And I just realized my laser pointer disappeared. My apologies. Okay, so now A, you can see going from coronal to apical is for a periodontal flap. I'm hoping that we never use B, because B is just horizontal and then you'd have a thick margin. C would be an orientation for the external bevel, and it would produce for the gingivectomy. D you would never do because it's running into the bone and therefore not an appropriate position, and it's also cutting off all the keratinized tissue because this line right here represents the mucogingival junction. So if you did this incision of D, you'd be taking off all the keratinized mucosa. Okay? All right. Now, the treatment plan from the midterm. Okay. So here you were given a scenario of a 60-year-old female. She had a swelling and discomfort on tooth number 3, a history of hypertension that was controlled with hydrochlorothiazide, and she was allergic to penicillin. She smoked 14 cigarettes per day, probings 2 to 8 millimeters, and then there was significant CAL, meaning loss of clinical attachment, ranging from 1 to 6 millimeters, especially in the maxillary right molars and the mandibular anterior. So the most severe bone loss was on tooth number 3, which had 65% bone loss. Mobility was present on teeth 2, 4, 23 through 26, and 31, which was type 1. And then there was type 3, tooth number 3 had type 2 mobility, and there was grade 2 furcation involvement on 2, 3, 14, and 15. So the first part of this question was asking the diagnosis. And I'm hopeful that one thing that, since you have to base the diagnosis on the most severe area, you can see that there's 6 millimeters clinical attachment loss. There's 65% bone loss, which as soon as you hit 5 millimeters of attachment loss, you now are at either a stage 3 or stage 4. I did not tell you that the patient lost any teeth, so they can't be stage 4. They're stage 3. And then, because the patient has 65% bone loss and they're 60 years old, the ratio or proportion of the bone loss by age is greater than 1. That puts you at a grade C. Plus, the patient smokes 14 cigarettes a day, so that also puts them at a grade C. And so hopefully you included in your diagnosis stage 3 and grade C. And then with this mobility, it be likely you could also suggest perhaps occlusal trauma, but not necessarily. But you should include a diagnosis for this swelling. So if the swelling on tooth number 3, with the 65% bone loss and the attachment loss, likely you either have a periodontal abscess or a perioendo lesion, but you would want to make note of that there was an abscess that needed to be further defined, and whether you included that, but you were also given credit for that in the points for that question. Because it definitely asked, were there any other diagnoses you could add in addition to the periodontal? Okay. Treatment plan. Key in the treatment plan, it should follow your traditional sequence. So you have an urgent need. You have to establish whether you have a periodontal or endodontic or combined lesion on tooth number 3, the patient's in pain. So hopefully doing the differential vitality testing, periapical, to reveal that, but that should be in your urgent phase. And if it's a periodontal abscess, that would be debriding that abscess endodontic. Then you would suggest endodontic treatment first. Then moving on in that treatment plan, certainly you would want to include smoking cessation and oral hygiene instructions. In addition, so those should be in the beginning of your disease control phase, and you would want to then have scaling and root planing listed. And if you thought there was occlusal trauma, incorporation of perhaps a bite guard, and a reevaluation of your initial therapy at 4 to 6 weeks. Just so I know you're still following me, am I being helpful at this point, or do you have any questions? Okay, thanks. All right, so we did diagnosis, treatment plan. Oh, I don't know if I needed to review this because I covered it out loud, but certainly the 5 millimeters greater, stage 3. So it sort of pushes you already there. And the case sort of matches that because I said you had furcation involvement as well. And, oops, darn. My apologies, I went to the end of the slides here. Let me go back. Okay, then this was just going over the grade C. So you do have to kind of commit to memory so you know the grading and in terms of the ratio. And then once you get over 10 cigarettes, you're definitely at grade C, and that 7% HbA1c are modifiers. Okay. So it's likely that I expect that we'll be giving you another treatment plan, and at this point, we're trying to figure out if we can give you a charting that you can print out in advance with clinical case material, but we're not sure if that works in the system yet. Okay, so then moving on, you want to go over the outcomes from surgery. So what you would expect, and in terms of how a gingivectomy may differ from an apically positioned flap, a replaced flap, or coronally positioned. And the emphasis on a replaced flap is usually to get primary closure and allow for placement and adaptation of regenerative materials, or we might even use a coronally advanced flap or coronally positioned flap. So their focus is on gaining attachment, as in clinical attachment level gain, as opposed to, let's say, gingivectomy or an apically positioned flap, which its focus is on pocket reduction. So we know that any flap will start with an internal beveled incision, and the gingivectomy is the only one that has the external beveled incision. And then in terms of clinical outcomes, we would expect recession after the gingivectomy and the apically positioned flap. And with the replaced flap and the coronally positioned flap, hopefully we won't see a great deal of recession, but all of them should attain pocket reduction, and we'll have a clinical attachment gain, hopefully with the replaced flap and the coronally positioned flap. We may have actual attachment loss with an apically positioned flap if we combine that with osseous surgery. Did all of that make sense? Okay. Alrighty. So in thinking about the comparison of the 2 semesters, this semester we focused on regeneration, last semester on resection. And so when we look at intra-bony defects, we want to have in your mind, when would we decide that we'd like to proceed with regeneration versus resection. And so you want to go back and look at some of the characteristics of bony defects. So as we have shallow, wide defects, then we lean towards, I just realized I'm not there we go. We lean towards resection via just apically positioned flap, osteosurgery to correct defects. Once the defects start to increase in depth, so usually at 3 millimeters or more, and if they're narrow, we're more likely to select a bone graft or some regenerative treatment. And then I wanted to just go over like furcations. Treating the furcations, you had a lecture by Dr. Sato discussing the different options, and the class 2 furcation is where we probably have the most options. Class 1 is usually treated with just maybe a little odontoplasty, but we could do flap debridement. Once we get a class 2, we may want to correct the class 2 furcation with regeneration, but our ability to do so could be limited, meaning proximal mesial distal maxillary furcations have a reduced outcome for regeneration. And then when you talk about a class 3 or 4, we may be leaning towards resection. And I think Dr. Sato presented a discussion where she talked about flap debridement, tunneling versus root resection. And then when would we resect versus regenerate or use an apically positioned flap? So I think I have the next thing. Oh, okay. I thought I had an image next, and I'll have it in a little bit so I can kind of go over that to help you with the practicing that. Okay, but I did want to make certain you want to review the different regenerative therapies. You will expect questions on the differences between allograft, xenograft, and alloplast. And these are all considered bone replacement grafts to accomplish defect fill. And then please review and know the definition of guided tissue regeneration and the steps for that. So I know my lecture talked about the steps of performing guided tissue regeneration and the fact that it takes advantage of differential tissue response. Then, in addition, biologics are incorporated into regenerative treatment, and some of the biologics could even be considered taking advantage of differential tissue response, but the ones that we have available to us today being platelet-rich plasma and platelet-rich fibrin are autogenous blood products that have growth factors concentrated. Then we have Emdogain, which is a porcine-derived amelogens, and Gem21S, which includes a carrier of beta-tricalcium phosphate, which is in alloplast, with PDGF. So please know what the products are, properties, and the potential outcomes. So that means just going through the slides that I covered on each of these. Okay. Here's the images. Okay. So in looking at the potential treatment procedures that you have, meaning bone grafts, guided tissue regeneration, or combination thereof for treatment of intrabony defects, when do we decide if we can select that versus just doing flap debridement. And keep in mind, you can just do flap debridement. You may not get definitive pocket reduction. So if we look at this image, we can see that there's a deep defect on the mesial aspect of the molar and one on the distal aspect of the molar. And it appears that there's a nice wall on the buccal of this defect. I think there's not a very deep wall on the lingual, but there looks like there might be a wall here. Then there's a wall on this side. It's a little narrower, but it sweeps here. So these would be considered deep defects. This one is less well contained because it looks like at the top it's just a 2-wall, and then further down it becomes a 3-wall. So we know that the predictability of a treatment of an intra-bony defect goes up with increasing number of walls to contain the graft that you're placing. And we would prefer not to perform osseous surgery to correct this, because as we have these deeper defects, this would entail removal of quite a bit of bone on this premolar, if you can see the laser pointer here, and the adjacent molar to correct the defects. You would end up scalping out this bone, losing quite a bit of support on these teeth. So we have deep defects. They do have some walls. To improve the outcome on this one, which looks like more like a crater, we would have to probably select combining with the barrier membrane to aid this one. Okay, and I have to move this out of my way. There we go. So here on the bottom, this is a dramatic example, but here we have an intra-bony defect that almost appears to go to the apex of this distal root and includes the furcation. So here, there's a lot that you could consider in terms of treatment options. I don't know if people want to put potential choices in the chat or okay. So anyone want to offer different treatment options here? All right, so I'll start listing some and you can see if you like them. Could we hemisect this tooth or bicuspidize it? It could be a possibility, maybe not your first choice, but with so much attachment loss on one root, you could section this tooth in half and perhaps remove this side, retaining one of the roots, but you would have to do a root canal and a crown, but you'd probably do a bridge, but you could do a crown here on the what you would retain, and that may be a way of dealing with this furcation. You could place a bone graft and a barrier and retain this tooth, which is, I believe, what we actually did. You could treat it with a biologic with the bone and the barrier, because this is a pretty complex defect, and we need to ensure that we're cleaning this furcation thoroughly, and that's when we usually incorporate root conditioning agents such as tetracycline paste or EDTA gel or citric acid will treat the roots before we go ahead and graft to make sure we've got everything cleaned. So this could be treated with periodontal regeneration. And I know that some may say, oh, maybe you should take that tooth out and put an implant in. But this tooth actually was treated successfully with periodontal regeneration. You would want to make certain that this was a vital tooth before you went ahead. Have I lost anyone? Are we good? So I was just coming up with like a discussion here. You could even amputate the root, but I think it makes more sense to bicuspidize it as if you wanted to be more aggressive. So all could be options with predictability. Alrighty, I think I've already covered this question. I think I put it here just to remind me. How to determine when to consider regeneration versus resection for pocket reduction. So if you have narrow interbony defects, I would consider regeneration. And that's the focus of contemporary periodontal therapy. But certainly if you have horizontal bone loss, super bony pockets, resective pocket reduction with apically positioned flaps are perfectly acceptable then. You have to have an area that can be regenerated. So you need bony defects. Okay. Why can't I get that? Okay, now this is a case that has a lot going on. I just wanted to use it to discuss and practice. When we look at this individual presents with quite a bit of etiology. You can see the brown layers of calculus and the gingiva is receded away. So you know this patient has attachment loss. But this patient has diabetes, has a great deal of financial stress, they're obese, and they smoke. So that's like at least four things that could push this patient to be a grade C in terms of the rate of progression and risk of progression of disease. And these are the bite wings of this patient. So when you look at it, you can see the advanced bone loss. I'm outlining with the laser pointer. Little chunks of calculus all along the way, lots of etiology, but what do you notice? Overall, there's a flat topography to the crest of bone. So in terms of a treatment plan for this patient, you would want to have a medical consult to make sure the patient's overall health is controlled. You want to have smoking cessation. You want to ensure that the HbA1c is under 7 before you go ahead with surgery. And we know the outcome to non-surgical therapy is even reduced in the presence of obesity and diabetes. So we definitely want to get that under control, and the same is true with the smoking. So how do we manage this patient? Well, we really don't have the potential here for regeneration. And that's because we have a flat topography, and I'm not seeing areas where we might be able to graft. Can we graft these furcations? Well, it appears that the entrance to the furcation is above the interdental level of bone, which makes the likelihood of grafting some of these furcations nil. So we have to have the height of bone to be higher than the entrance of the furcation. So we have some bony compartment to contribute to the wound healing. So this would be treated with a classic resective technique of apically positioned flap with osseous surgery to reduce ledges and make for a positive architecture. So that's really why I added this in, just to go back to, okay, when do we have to do resective therapy? Because if we have all of this as the pocket, we need to bring the margin of the gingiva down to the level of bone. Okay. Then I also wanted to cover, you want to review the indications and limitations for the mucogingival procedures. So we had the free gingival graft, lateral pedicle flaps, and I know that they were introduced to treat gingival recession, progressive gingival recession. Then there's the subepithelial connective tissue flap technique and coronally advanced flaps. So you want to know when they can be used and when they can't be. So for example, we can't coronally advance tissue if there isn't enough keratinized tissue, if we're hoping for root coverage. We certainly can coronally advance to cover a membrane and bone if we have supportive interdental bone height. Okay, but in focusing on just mucogingival, make sure you understand the role of the free gingival graft, the role of the lateral pedicle, and that of the subepithelial technique. Then you want to also know the outcomes possible. So free gingival graft, you're going to get increased keratinized tissue, increased attached gingiva when you're done, and increased vestibular depth, depending on where you place that graft. The lateral pedicle, you might get some pocket reduction, you might get root coverage, but you certainly should get increased keratinized tissue. So the other thing that you want to review are the factors that impact progression of recession. So that's being frenal or muscle pulls, inadequate attached gingiva, and the impacts on the ability to do root coverage, where you want to go back and review the Miller classification. And then I covered prominence of teeth, crowding of teeth. You need to have good soft tissue dimension adjacent to the recession defect if you're going to have a collateral blood supply. So all of those were covered in Aesthetics 1 and Aesthetics 2 lecture. All right, so just as a kind of review, what would this match in terms of this flap design? I'm hoping you can see what you're looking at here. There's a vertical here and a vertical here. The flap is actually being retracted up here. So you're seeing a bed, I'm hoping you're seeing that, that's bleeding. So what does that mean? That means it's partial thickness, because I'm not seeing pristine white bone. And I'm seeing a CEJ here, where I put my laser pointer. So this is all a root dehiscence. So if you saw this, I would think that you'd recognize that this is probably a partial thickness flap in preparation for root coverage versus pocket reduction. Because if we're doing pocket reduction, we need both a buccal and a lingual flap to get access to those interdental defects and to clean out the granulation tissue. Okay. And how much time do I have? Okay. It looks, I wanted to go through this case because it's a good case to talk about diagnosis and what you're looking at. So this is the presentation of a patient, and they are in pain. And so you're seeing the facial view here and the lingual view. And I'm hoping you can appreciate there's some slimy areas here. I know slime is not a clinical term, but you see the slimy areas here. I'm putting my laser pointer here. There's some fiery red tissue here. And I'm seeing blunting of the papilla. Fiery red tissue here. And then you can see the accretions, the calculus here. So pain, fiery red, looks like it's bleeding, and if I said the word pseudomembrane, I think it gives it away. What do you think we're looking at? Okay. I'm hoping someone says, well, this could be necrotizing periodontitis or ANUG, but it probably is more likely necrotizing periodontitis because I can see that we've got calculus over the root and it looks like there's recession. So likely that there's an area here of necrotizing periodontitis. And this is the radiographic series that goes with this patient. Overall, there's quite a bit going on. So when we think about necrotizing disease, usually the patient has some risk factors, meaning maybe poor oral hygiene, lack of dental care, stress, maybe poor nutrition, maybe drug abuse, all could contribute to being immunocompromised, meaning alcoholics may also be at risk, but certainly stress and could also impact, so any point that creates stress. But here, this patient has bone loss, so it's probably necrotizing periodontal disease or periodontitis. Okay. Then I'm just going to go through some clinical cases to get your juices flowing here. This is a swelling located between T22 and 20. And when you look at, this is the associated radiograph, I think you can appreciate there's a bony defect in the same, but the patient presented with the swelling. So what would you likely conclude, and how would you go about deciding what this was? So from I went over in the beginning the midterm question, but I would hope that you'd first pick up your perio probe and kind of walk around the tooth, and you might palpate to see if you're getting pus. You want to determine, is it related to pocket depth and not to, let's say, a neoplasm, but it's fiery red in this area, and you can see there's bone loss over here as well. But you can see there's bone loss here, and if it's associated with periodontal probing, it's likely to not be a gingival abscess, but a periodontal abscess. And then how would we treat this? Well, the first step would be to at least scale and root plane and try to get out the etiology. And you'd have to do that with getting the patient numb and getting the patient's home care back in order. And then subsequent to that, this bony defect would be certainly one that you would consider for periodontal regeneration. So you could use a barrier membrane in combination with the bone graft would all be acceptable here after you've done initial therapy and gotten home care under control. Okay. Then if we look at this case, I put this here to practice a problem list. And when I look at this case, I put it here because the patient is really unhappy with this bridge. And it unfortunately is a new bridge. So when you look at it, overall, I hope you can appreciate that as I go through this topography, this is not a topography that matches an aesthetic smile. So what's happening here? Well, it looks like, if I were to list a problem list, we have gingival recession, uneven gingival zeniths, and it looks like this patient actually chipped this restoration. And then there's a reaction around the lingual aspect, and I think it could be due to the proximity of this crown margin under the gingiva, and now it's recessed. So maybe a violation of biologic width. And then we got an open margin here. So we have poor crown margins that are plaque retentive. We have placement of a margin that was probably subgingival, and now the tissue's receded, and we have uneven topography. Then we have recession over here, and this tooth has chipped, but in terms of problems, it appears that there's also a violation of biologic width. So to solve this, probably would end up having to do root coverage on canine number 11, crown lengthening to even out all of the gingival zeniths, and probably new restorations to match the correct location of the gingival zeniths. And if this margin has to be that far coronal on tooth number 9, it may mean that we have to scallop out the pontic area to make that longer. But basically, this would require a wax up to get everything even. Okay. And then how would we treat this area? Well, some could choose to do osseous surgery to fix this because we've got reverse architecture. There's a defect on the mesial of the second molar and a defect on the mesial of the first molar. So we always define the defect as being associated with the tooth that's at the deepest point. So it's pointing towards this and this. So at this point, we could consider regeneration here, but it doesn't seem to be very well contained. But as we look at the depth here, and this premolar has little to no bone loss, I don't think we'd want to make it match this level. So I think we'd end up wanting to select regeneration here, but it won't be easy. We have to rebuild using a barrier membrane and then the bone to support the barrier membrane, because we're missing this wall on the, I guess it's the buccal aspect, because we're looking at the lingual side. So here, we may even want to incorporate biologics to aid or enhance the outcome. Whereas the defect between the two molars could be corrected just with osseous surgery. But this we could try to graft as well. Okay. And then, here, I just wanted to go over, if you're looking at the before and the after, what procedure was likely performed. So if I'm looking at this pocket depth, looking at a thick band of tissue, and now I'm looking at a bleeding surface and I'm seeing some of the roots exposed, I know that a resective procedure was performed, and with a flap, I'd have sutures, not a raw surface, because when you do a gingivectomy, you are exposing the connective tissue and tapering that connective tissue coronally. So this is demonstrating a gingivectomy. Yes. Okay. And then okay. Then this is an example of where you have short clinical crowns, likely due to altered passive eruption. And then in the second screen, you can see that I now see these mandibular incisors, and I have suturing, so I know there's probably a flap that was raised and then it was apically positioned. So it was doing a crown lengthening procedure via an apically positioned flap. Okay. Not remembering why I put this here, but okay. I think it's good to talk about teeth with bony defects and furcation involvement. So if we were to treat this area, would we expect scaling and root planing alone to be successful? And I would say no, for the reason that we have an intrabony defect here, and it appears, let me get the laser pointer back on. It appears that we have a furcation arrow here suggestive of a furcation. I can see it in both images present. So we could consider an apically positioned flap with osseous surgery. We could consider regeneration, but we know that if there's a proximal furcation, it's more difficult to be successful with regeneration of that furcation if it's on a proximal surface, because it's difficult to debride and difficult to isolate with a barrier membrane. Okay. I think you had this image on your midterm. So if you look at this image, you're seeing, it may be hard to tell, but the tissue, this is necrotic tissue right here, and the patient had pain. So this is illustrating when you say pain, spontaneous bleeding, and a fetid odor, that all is a constellation for necrotizing disease. And go back and review your wound healing, because you'll want to be able to know the outcomes of the surgery. And in terms of regeneration, we know that we would not be expecting to see defect fill on a radiograph until 6 months or later, because it takes time to get the bone remineralization of the graft until 6 months. But we know, based on general wound healing of a flap, we don't probe our patients until 3 months after any flap surgery. And that's because of the length of time it takes to get the new bone, ligament, and cementum and get it back to the classic fiber orientation, being perpendicular rather than parallel. So that was wound healing, which was last semester. This was just a practice what procedure you thought happened. So if this the top row is pre and the bottom row is post, what do you think occurred? And hopefully you notice that from the top to the bottom, there's recession. So in order to have recession, there has to be a resective procedure, and we only have really two choices: a gingivectomy or a flap with osseous. So we know it's not a gingivectomy because we still have keratinized tissue here. And if we did a gingivectomy, we probably would have cut off all that keratinized on this buccal. So it's likely that it was a apically positioned flap with osseous, and someone answered crown lengthening, which would be correct, meaning apically positioned flap with osseous surgery. Okay, so this is just reviewing the steps that we take in doing a surgery and knowing the difference between the apically positioned flap and replaced or coronally positioned. If we're going to do a coronally advanced or an apically positioned flap, that flap has to go past the mucogingival junction. So if we want to coronally advance up, we have to go past the mucogingival junction to get into that alveolar mucosa. If we want to move it down to get pocket reduction, then we have to, again, go past the mucogingival junction. But we know that all flaps have an internal beveled incision. If we're treating pockets around teeth, it's full thickness. If we're treating a mucogingival defect, it may be a partial thickness. But if we're trying to get access to the bone, then we're going to probably go past the mucogingival junction so we can perform the osseous surgery and then apically position the flap. So the bottom line is we get pocket reduction at the expense of the final attachment level, and we get more root exposure and recession if we apically position a flap. Okay? And then what procedure is likely to have been done here? We have, if you can see it, this is the mucogingival junction here, and you can see a frenum pole, and there's this recession here. And then this is what it looks like after. So what do you think happened here? Well, I'm hoping that you think a possible free soft tissue graft, because we've increased, if you notice it, we've increased the band of keratinized tissue, and there's no longer this frenum. So in the bed preparation, so usually that bed starts up at the mucogingival junction, and you dissect down a partial thickness bed to put your graft, and that allows for the establishment of a different mucogingival junction, more apical. So you've increased the vestibular depth, you've increased the band of attached gingiva, all of which are outcomes following a free soft tissue graft or a free gingival graft. Okay. And I think this is the last thing. Am I out? My apologies, I've gone late. Well, I just wanted to go over perio restorative interface, just to go over what GBR is versus GTR. So guided bone regeneration is for edentulous ridges. It's for ridge augmentation, as opposed to GTR, which is the T there stands for tooth, but not really, because it stands for guided tissue regeneration. But if you're trying to make sure you're not getting confused, because our residents will do this, GTR for tooth, GBR for bone. Okay. And that was it. If there are any questions that I did not cover, you can certainly ask. I think you have several weeks more before you have the exam, and I can post a study guide in the section so that you have this as a